My name is Elizabeth Stevens. I'm a congenital cardiac surgeon at Mayo Clinic. It's my pleasure today to be joined by Dr. Niaz. Thank you for joining us. He specializes in pediatric cardiology, but also genetics and aortopathy. And today we're going to talk about surgical interventions in patients who have aortic conditions. And there are a number of conditions that involve the aorta. Maybe, Tala, you can talk some about those conditions.
Thank you. It's a pleasure to be here today. So the conditions that we're going to be talking about today is the aortopathy. Aortopathy refers to a group of conditions that affect the biggest artery that comes out from the heart, and this artery is called aorta. And there are a number of different connective tissue conditions that tend to affect the aorta as well. When we think about connective tissue conditions, these are the conditions that affect almost every different organ and different part of the body, because connective tissue is present everywhere inside the body. And if that structure is weakened, that can also weaken the aorta. So a number of common conditions that we see in this domain is Marfan Syndrome. There are other conditions like Loeys-Dietz Syndrome and similar other conditions based on different genetic diagnosis. In terms of Marfan Syndrome, this is one of the most common form of diseases that affect the aorta. And in Marfan Syndrome, we see a lot of different features and clinical presentations, which may include some very long fingers, tall stature, some caving in or caving out of the breastbone or sternum. There could be curvature of the spine and some other skeletal type of features. In addition to that, the most serious consequence of the Marfan syndrome is the dilation of the aorta. In a similar grounds, we have people who can also present with Loeys-Dietz syndrome, and these patients can have much more severe phenotypic features. And it's particularly to note this for pediatric patients because a lot of these patients can actually present very early on and may require surgical interventions for the aorta even during young childhood, even way before the teenage years. In addition to that, there are other conditions too. For instance, Turner syndrome that can affect the aorta. There are valvular conditions like bicuspid aortic valve that can also cause aortic dilation.
Great, super helpful. One of the things that I think is really fascinating is how for Marfan syndrome, we see such a variation in how they present both age and sort of the spectrum of organs that are affected. Can you talk a little bit more about that?
It is very fascinating to note that there is quite a bit of variability in the presentation among different patients with Marfan syndrome. Some of that stems from the area of the gene that is affected. In a very severe presentation, which we call neonatal Marfan syndrome or early onset Marfan syndrome, the segment of the gene that's affected leads to much more damaged protein product. And as a result of that, we have really early onset presentation right after birth, where there can be a lot of skeletal concerns like very long bones, hypotonia. There could be lung diseases, which could be related to some of these manifestations. And infants with this can also have quite significant cardiac presentation too. In addition to that, we also see that even among the family members who have similar genetic change, there could be actually a very variable presentation. So this is something which we are still trying to understand and know how this really works.
That's fascinating.
Now, in terms of the management of these conditions, when I see these patients in clinic, there are a group of different medications that we can try for these. Some of these medications are beta blockers or ACE inhibitors. These are blood pressure or heart rate medications. But I would be interested in kind of your thoughts on, from the surgical management of these, if you can elaborate your approach to these patients and what are the surgical managements?
Yes, great questions. And we do have, I'll bring up a diagram here that shows, so from a surgical standpoint, the main area in those Marfan's patients in particular that dilates is this base of the aorta. So this is where the aortic valve is, and this is the ascending aorta, and this is the arch. So in this case, as this dilates, two things happens. One is they're at risk for dissection, and so that's a tear in the aorta and can have very severe consequences. The second thing that happens is that as that area dilates, the aortic valve gets stretched apart, and that can leak with time. And so over the years, we've determined, based on research studies, in terms of the risk pattern of these patients, at what point we would recommend surgical intervention. And for many patients, if their aortic valve is still the tissue is good, we can actually save the valve and cut out the aorta around it, which is shown in this diagram here, and basically replace this aorta, make it smaller, and then reattach this valve. Shown here are the coronary arteries that also need to be detached in this process. And this is called a valve-sparing aortic root replacement, and can be a very good option for many patients. For other patients, the aortic valve may be damaged and they may need a replacement. This shows suturing the graft around the valve. And then this shows the finished product. So the coronary arteries are also sutured in place. So this protects the patients against aortic rupture or dissection, but they still need ongoing management, ongoing surveillance from someone like you, and maybe you can talk more about what after surgery, from a cardiology standpoint, they may need.
I think that was a great description of the surgical intervention. So going forward, definitely a lot of the patients will still require ongoing surveillance and follow-up. Now, after this initial surgery, the concern for dissection or tear in the aorta, in that root of the aorta or the ascending part of the aorta, is definitely quite low now. But still there is a segment of aorta that's after this graft. And that segment has a slight risk for dissection over time. We generally call this a type B dissection. Now, in order to do surveillance for this, we'll still do imaging. Different imaging modalities could be used. We can use echocardiogram. In addition, we can also look at some other modalities of imaging like CT angiogram or an MRI. And these can help us in surveil these segments over time. Also, I would like to point out that this is a disease that affects multiple systems and organs of the body. So as a part of just the management of the disease, I think it's important for individuals to be followed in a very systematic way to look at all these other organ systems and approach these other concerns that can arise over time in a multidisciplinary manner.
That's a great point. And you're a pediatric cardiologist by training with additional training, and we've talked about patients who present as babies and as children. And then as they grow up, they're going to still need to be followed. So maybe you can talk a little bit more about how does that happen? Once they become adult, what happens in terms of their surveillance and their medical treatment?
Absolutely. So this is, again, a lifelong follow-up for these individuals. And when we think about in the pediatric time frame, there is a lot of different subspecialties involved, whether that's ophthalmology, orthopedics, physical therapy, and some of the other subspecialties as well. In a similar manner, at Mayo Clinic, we have a great program that's run by our adult congenital heart disease specialist, and it's a program that's dedicated to aortic disease and aorta. And we have a very seamless transition for some of our patients who can go from pediatric cardiology into the adult specialties, and we work in very close association with them. So it's absolutely a necessary thing for these patients to transition to a group of physicians who really know these conditions well and then could also manage similar ongoing concerns over time.
Great. Well, I want to thank you for your time and your expertise and all your care of our patients that we've shared over the years. And I would like to thank you all for joining us for this YouTube video. We appreciate your time, and feel free to reach out if you have further questions. Thank you.